of the lesion describe the cytological change. Okay, so actually we don't have the gross specimen, but I give this picture to see how is the lesion usually. How is it? It's like a warty lesion. See, elevation from the skin shaft. This is the skin shaft of penis. Okay. So it is like elevation of lesion, about fleshy lesion. Okay. You can this one. This one. This is what we expected gross picture. Okay. So our slide. Our slide. This one. Okay. Okay. Hello? Yeah.
Yes.
Hello.
Okay. This is the normal area. Can you see? And this is the abnormal area. Okay, we can magnify. Okay. I'm to show you how is the normal. Okay. Look at this one. This is the skin. This is the epidermis, and this is the dermis. Okay. This is the dermis, and this is the epidermis. Look at here. This one is the basal layer. See? And this is the intermediate layer. This is the outer layer. Can you see the outer layer is flattened, and here is keratin.
Keratinous.
Keratin.
Yeah, see, this is the mature tissue. So you can see the basal, the intermediate, and the outer layer. So there is a difference, and there is no hyperchromasia, polymorphism. Is normal squamous, stratified squamous epithelium. Okay, you more magnifying. Can you see the bridge between the cells? The connection.
Yeah.
This is indicate the maturation. Okay. You will see what are these brownish color is the melanin actually. Melanin pigment. Okay. Okay, this is the normal area. Okay, if we move to see what is the difference. Is there any difference? I just move. Can you see any difference? Is there any difference?
Yes.
Yes.
What do you see?
Abnormal proliferation.
Hyperchromatic cell.
Mean dysplasia, right?
Yeah, all of them look like the basal layer.
Is there any difference between the basal layer and the outermost layer?
No.
No, same, isn't it? That means there is loss of maturation. Okay, loss of maturation of the epithelium. Okay, what do you say? Is it mild or moderate or severe dysplasia?
Severe.
Severe. Why? Because it involves the full thickness of the epithelium, see, from the basal to the outer layer. So this is severe. Okay. So what else we see? Then we can see the cytological change. What happened to the cells? Is it normal? No.
No.
What we can see? Polymorphism, isn't it?
Chromatic.
Hyperchromatic nuclei. What else? High
Mitosis.
impurity. High impurity, isn't it? Increased mitotic figure. Usually the mitosis where? The normal mitosis where we can find?
Basal layer.
Basal layer.
Yeah, in basal layer. But here we can see the mitosis in any layer. See, like this. In the outer layer, this is mitosis. Yeah. Okay. But here, what is the one thing very important is what? What else we say? Very important. What are these?
Innovation.
Intact.
Intact. Intact basal layer, I mean basement membrane. So this lesion is considered is what?
Benign.
Is it benign?
Carcinoma in situ.
Carcinoma in situ.
Yeah, carcinoma in situ. No invasion. Okay. See how is the marked variation in the size and shape of the cells and also nuclei. See, so why these cells like this? I mean, the nuclei is surrounded by clear cytoplasm. What we call these cells?
Keratinocytes.
Yeah, poilocytic. This indicates what? The poilocytic.
HPV.
Yeah, HPV infection. If you see this poilocytic cells, that means this due to the HPV infection. Okay. Okay. Any question here? So we see.
Doctor, is it cellulocytic?
Is what?
You said it's cellulocytic or
Poilocytic.
pilocytic?
Poilocytic cells, not cytocytic. Coilo.
COLL.
Yeah. See, look at the pre-nuclear halo. Okay. So how we describe this? Warty. See, first is like wart, isn't it? Look at the lesion. It's like warty lesion, right?
Yes.
Can you see this is warty lesion?
Yeah.
Okay. Showing severe dysplasia. Means severe dysplasia is what? How to describe severe dysplasia? We said loss of maturation, also loss of orientation, and also cytological changes, which is hyperchromatic nuclei, polymorphism of the cells, and also nuclei, right? Increased mitosis. What else? Choriocytic cells, presence of choriocytic cells, and the features is involving the dysplasia involve the full thickness of the epithelium. And this thing is very important, but still the basement membrane is intact. Okay, this is the, see, look at here, this is the underlying tissue. This area is not invaded yet. Look, there is a demarcation between the epidermis and dermis. Okay, the underlying tissue. Okay. This one, the brownish color is the presence of melanin. Understood?
Yeah.
See how is much difference between the normal area and the abnormal area?
Doctor,
Yep.
what involves the proliferation till the outer membrane?
Sorry, the proliferation.
You say something that involves the whole from the basal membrane to the outer
The
part.
dysplasia.
Or dysplasia. Alright.
Even see, not look at here. Here is the layers. It's a few layers, isn't it? The skin, isn't it? If we compare the thickness, here it's warty lesion, so increase even the layering of the skin. But I mean the changes is dysplastic changes. So the dysplasia involving the full thickness of the epithelium. Okay. Okay. Any question? Any question?
Doctor,
Yeah.
what's the difference between coilocyte and metastasis?
No, metastasis is the I mean, in dysplasia, did the dysplasia metastasize? Anyone can answer? Is dysplasia can be metastasized?
No, it's not cancer.
No.
It can be
No,
premature.
it's not. It is pre-malignant. It's not. I mean, malignant yet, because it's still within the epithelial layer. It's not. The changes only in the epithelial layer. Is not invading the underlying tissue. This one, the tissue which is the epidermis, the dermis. The changes only in the epidermis. Okay. So it's not metastasized yet, because metastasis should be invade first the underlying tissue, isn't it? Then invading the blood vessels and lymphatic, then metastasize to other organ. Coilocytic, we said just changes inside the cells. See the pre-nuclear halo or clearing, okay, surrounding the nuclei is due to actually the HP virus infection. Okay, so this lesion we call bionoid papulosis. Is bound disease. Bound disease is caused by human papilloma virus. Do you know the pathogenesis?
Yes, doctor, you told us.
Okay, the pathogenesis is same as
Cervical cancers, cervical intraepithelial.
yeah, same. We said how the pathogenesis. Can you tell me?
The protein
E6 and E7.
protein actually blocks the tumor suppressor gene, right?
We said first that this virus is what type of virus?
HPV.
HPV.
Yeah, I know. What type of virus? You have two types of virus, right?
It's a DNA.
DNA. So it will incorporate it inside the nuclei, right? When incorporated inside nuclei, so it produces oncoprotein, which is E6 and E7. E6 bind to P53 and E7 by retinoblastoma. Those are tumor suppressor genes. So when it binds to P53, it will cause degradation of the P53, right? And also inactivation of the retinoblastoma, so the cell will be proliferative, isn't it? Uncontrolling proliferation of the mutated cell And with clonal expansion, it leads to the dysplasia and then cancer. Okay. Same thing as in the cervix.
Doctor,
Yep.
I have a bit of an unrelated question, but I just want to know is there any possible conditions where you have like a benign-like condition involving your basement membrane, or if it's involving your basement membrane, it's always going to be a malignant condition?
What do you mean by benign?
I mean that it does not spread further, but normally if it involves the basement membrane, it spreads further, right? So I just want to know if it involves the basement membrane, is it always considered malignant?
Once it is break the basement membrane and invading to the underlying tissue, in this case you call it carcinoma. We call infiltrating squamous cell carcinoma.
So you can have a condition where you might have benign-like changes in the cells of the basement layer, but let's just say if it does not break off, it can still be considered benign?
We call neoplastic, okay? We cannot say benign, because we said the benign is different.
Okay, alright, okay.
Because benign cannot be progressed, because we have mild, moderate, and severe, right? Changes. Mild and moderate can be reversible, you know. If the patient treated with the HPV, it can be reversible to the normal skin. But severe is pre-malignant. It can progress very fast. You know, if they not remove this by surgery, it will lead to progress to the malignant. In this case, they will remove the whole penis. Okay? Because it's already invading the underlying tissue, the dermis. In this case, the treatment is penectomy. And also chemotherapy, radiotherapy. So it is better if we have to screen the tumor in early stage, especially in this plastic stage. It's easy to remove it and no need for chemo and radiotherapy. Okay?
Alright, okay.
Any question? Okay?
Doctor,
Yep.
let's say if this lesion infiltrates the basement membrane, does it become neoplastic or is it still dysplastic?
Actually, the neoplastic we said is also considered neoplastic, you know. I mean, neoplastic is not indicating only for the cancer. Faham?
So we can consider this as neoplastic as well, is it?
Yeah, it's considered because it is started the changes in the epithelium. But if mild and moderate can be reversible.
Oh, okay.
In severe, I don't think it's reversible. It will progress to the infiltrating cancer.
All right. Thank you, doctor.
Okay. Any question?
Doctor, for the part where they say what's the prognosis, what do we say? Is it it's very bad because it involves the whole thickness of the epithelium?
No, it is not bad. It is good. Still good. Because it's still dysplasia.
It's severe dysplasia.
Yeah, but the prognosis is still good. You know, because if removed.
It's not cancerous yet.
Yeah, not cancer. It is pre-malignant.
So bad prognosis would mean if it only infiltrates and breaks away from the basal layer?
If infiltrate, consider bad, especially if I mean, if invading also the blood vessels and lymph nodes, we consider bad prognosis.
Doctor, so if it's pre-malignant, so if it does not receive treatment, it will be malignant, is it?
Yeah, it will progress to the malignant.
Oh, all right.
Okay.
Doctor, one more question is there, but there's no assurance to the patient that even if this portion is removed, that this plastic portion is removed, that he won't have any further further tumors in the future, right?
Sorry?
Even if he has this part removed, this plastic area removed, there's still chances of him having tumors in the future, right?
Yeah. And some articles, they said the bionoid papulosis may run as a benign course, and it can be regress, but it's need to follow up 3 to 6 months. Okay, but in severe dysplasia, the bound disease is actually pre-malignant. If neglected, is not treated, it will progress to the malignant. Okay. Okay, I can move to the second case. The prognosis actually is good. We said good because no invasion. Okay. So, you know, some Bowen disease or bionoid papulosis, some of them disappear. Some of them not disappear. In this case, we have to do surgery. Okay.
Doctor?
Understood.
Doctor?
Yep.
Just now you mentioned about this area. What is it, doctor?
Which one? This area?
Upper left.
Upper left.
Over there. Yeah, yes.
This one, the underlying tissue?
The underlying tissue. So
yeah, the underlying is the dermis, the dermis.
Okay, to see either it is invasive or not, how do you see that?
Actually, how we know? It should be this basement membrane is breached or breached, okay? And some of the malignant go into this area, to the dermis. But here, can you see the basement membrane is still intact? No breaching. You know?
Okay.
Okay. Understood? Can I move to the second case?
Yes.
Wait, doctor. So these are all neoplastic cells, and they can't be classified as benign tumor, is it?
No. It's not benign.
Because the cells are not
behavior like benign behavior is different. The behavior, they said, maybe regress. Some of bionoid papulosis can be regressed spontaneously, but some of them is not regress. So in this case, we have to do the surgery. Otherwise, it will progress to the malignant. Because we said the benign tumor is not transforming into the malignant, right? And also the benign tumor doesn't have this feature of dysplasia, right? So it is not benign. But the condition is still pre-malignant condition. Okay? So what we call this condition, we said bionoid papulosis. Okay? What is the most likely etiology is HB virus. And the prognosis, we said good prognosis because there is no invasion. Okay? Okay, second case. Okay. second case is Madam A is a 40-year-old lady had a pap smear done during a recent health camping in her village. When the result came back to abnormal, she had to undergo a biopsy, which confirmed the pap smear finding. She later had cone biopsy for definitive treatment. Okay. Also, we don't have specimen for CIN, but this is a picture to see how the lesion, okay, the expected lesion. See, yeah, this is the ectocervix. Okay, we said the cervix has endocervix and ectocervix, right? Most of the changes of CIN is started in squamocolumnar junction, right? So this is the ectocervix, usually lined by stratified squamous epithelium. So look at this is the normal. In low grade, it is like, like a whitish lesion there. So this is in the high grade. Okay, cancer usually have tumor. In CIN, you cannot see really mass or tumor. Okay, you just see the whitish area in the acetic. When we do the acetic, we call aceto white. When the acetic acid, we do the test, it look like whitish color, the abnormal area. Okay, so you can see that this is the lesion, can be CIN3. Okay, okay, I can show you here. We said the normal, we have basal layer. Okay, first this is basement membrane. This one the basal layer, then the parabasal layer. Okay, superficial. Okay, so there is maturation. When you go up, the cells is become more flattened. See, in mild, we said that in mild involve how many parts of the epithelium?
1/3.
1/3.
1/3. We can see the malignant started in 1/3 of the epithelium. Yeah, mild. We call this mild or CIN1. CIN2, we said 2/3 of the epithelium. See, still the outer layer still not involved. Okay, so in CIN3 is have the whole thickness of the epithelium, and there is no difference between the basal and the outer. Same, they are filled with the dysplastic or malignant cell. But look at here, the basement membrane still intact. In invasive carcinoma, see it breaking the basement membrane and they invading the underlying tissue. Understood? This one we consider carcinoma in situ, the CIN3. Okay. It is pre-malignant. It can progress to the invasive cancer. Okay. Any question here?
Dr. Please, technically there's no real difference between severe dysplasia and carcinoma in situ, right?
It's the same.
It's the same, right? Yeah.
Same. Why we said carcinoma in situ? In situ means still within the epithelium, haven't break the basement membrane. So it is inside. If in duct, still inside the duct. If in the gland, still inside the gland. If in epithelium, still inside the epithelium. We say in situ, carcinoma in situ. You know the difference between invasive and carcinoma in situ, only the invasiveness. But if you look at the cells, same cells, malignant cells, high NC ratio, hyperchromatic, polymorphic, mitosis, the same things, loss of maturation, but the difference only in the invasion. Okay? Okay?
Okay.
Okay.
Okay, so let's see our case. Okay, look. This lady did Pap smear. Remember our Pap smear in the class? We said high grade or low grade. She got high grade dysplastic cells. Then she did biopsy, then cone biopsy. We said cone biopsy as curable. Means if she has CIN3, so what is the treatment? Just do the cone biopsy, okay? Cone biopsy means they cut the cervix as a cone shape, okay? So this is pieces of cone biopsy. Usually sometimes, you know, when we have to process the whole cone biopsy, sometimes we have, you know, how many pieces? Maybe it reached to 15, 20 pieces. Sometimes I have to screen about 10 slides. This is one slide, have this 1, 2, 3, 4, 5 pieces. Okay? So we have to screen and see where is the tumor exactly, and we have to. Can you see the ink, the black ink here? We have to stain the margin. Okay. So okay, look at here. Okay, I will show you this. Okay, what do you see? Like gland, right? Can you see there? This is the stratified squamous epithelium. Can you see? This is the basal layer, and this is the intermediate superficial layer. Okay. And what are these? What are those glands? Isn't it? Isn't it?
Yeah.
This is the gland. This one is endocervix. Okay, and we said that the changes usually in the squamo-columnar junction, right? So this is the area of squamo-columnar junction. Okay, this is the normal, actually, ectocervix. You can see the maturation, the basal layer, the intermediate, the superficial layer. It is the flattened. Okay, just go and just move and see what happened in this epithelium. So what do you think? Is this still the same?
No.
Oh.
There's loss of maturation.
Yeah, look how is in this area. What do you think? Which type of CIN?
CIN3.
For me, it's CIN2 because I can still see the outer layer. Okay, but just move a bit. Okay. In this area? See?
CIN3.
Yeah, CIN3. See, you can see all composed of malignant cell. Look at the fold thickness here is filled with dysplastic cells, isn't it? So dysplastic cells. So what do you describe? The cells are high in C ratio, right? High in C ratio. Hyperchromatic, polymorphic, isn't it? It is mitosis, a lot of mitosis here. Can you see the difference, mark, variation, polymorphism? Okay, I can show you what are these between the cells.
Interepithelial junctions, intercellular junctions. I mean.
Yeah, intercellular bridge. This is the. This is the characteristic of squamous cells. You know, in poorly differentiated or moderately differentiated squamous cell carcinoma, you cannot see this kind of intercellular bridge. Only in well differentiated. This one, the dysplasia is still pre-malignant, you know. So you can see the cells still what you call well differentiated. Okay. Look at the basement membrane. Is intact, right? No invasion. No invasion, right? Do you see any invasion?
No.
No invasion. Okay, I can show you why. Okay. Okay. If you see this one, you will tell me this is, oh, doctor, this invasion. Is it invasion? See?
No.
So what are these? And
benign growth.
Oh, it's not benign, actually it's the same. Okay, why this? Look at this. It's like gland, isn't it? This look like gland. Why there is is filled with malignant. Actually, this one, the CI entry, you may think this is invasion. It's not invasion. Actually, extension of the CIN through the glands, the cervical glands. Okay. Because if there is invasion, so we said if there is invasion, usually we have desmoplastic reaction, right, from the stroma. I cannot see the desmoplastic reaction. Also this one, look here. Can you see?
Can you repeat that? What is the desmoplastic reaction?
Can you see there? The glands, okay? And this one, the CIN started to extend through the gland. Can you see?
Yes.
Yeah, this is extension actually, is not invasion. Invasion should be break the basement membrane and invading the surrounding. Okay. So this is the endocervical gland. Look, they are lined by mucus secreting epithelium or columnar epithelium secreting mucin, not mucin, mucus. Okay. Okay.
Right.
Look at the cells. See, this is the mitosis. Can you see? Okay, this is mitosis, unipolar, isn't it? See, very marked variation, polymorphism. Okay. Any question? So this consider CIN?
3.
2 to 3. Because some area is showing 2, isn't it?
Yeah.
Okay. So we said the features of dysplasia, polymorphism, high NC ratio, hypercrosia, loss of polarity, abnormal mitosis, loss of maturation, right? So what is the most etiology here we said?
HPV.
Yeah, HPV. You know the pathogenesis, right? Look at here, choleliocytic cells. Okay. Also here. some coilocytic. You know, the coilocytic is not just there is a pre-nuclear clearing or halo. The nucleus should be hyperchromatic and irregular. You know, irregular nuclear membrane. Okay. See, like this one. Okay.
Okay.
We already explained the pathogenesis, how to explain. So what is the significance of detecting this lesion in screening pap smear?
Prevention of cervical cancer.
Yes, very good. You know, I give this question for year 2. Oh my God, the majority fail. I give the same case like this discussion. The pathogenesis, you know, the significance, why she done, what is the treatment. Treatment here is, we say comb biopsy, right? Even we discussed during class, but they didn't answer very well.
Doctor, isn't the comb biopsy a detection test? Not a. Is it a treatment?
It's a treatment. It's not. The screening test is pap smear.
Okay. So comb biopsy is when you remove the whole infected part.
Yeah. We remove the as a cone the whole. Because if you leave it this one without treatment, you know, it will progress to the
invasive carcinoma.
Yeah, invasive infiltrating. You know what is the treatment after that?
Chemotherapy?
No, total hysterectomy plus chemotherapy.
Oh, yeah.
Then remove the lymph nodes.
Yeah, and the pelvic dissection, you know. So very big, major, you know, surgery. You have to remove the uterus, the whole uterus. Just imagine the whole uterus plus the ovaries, the fallopian tube, everything. You have to remove it. And also, you need to dissect the pelvis to remove the lymph nodes. And after that, chemotherapy. So why pap smear is very important screening? We can even detect.
Early detection.
Yeah, early detection. You know, we can see the CIN1, even, you know, before the CIN1, the atypical cells. Sometimes in biopsy is normal epithelium, okay? But in pap smear we can see even the 1 or 2 cells started to change it. In this case, you have to do follow-up every 6 months. So if there is any increase, in this case, we can do the, you know, either to treat it from the HPV or biopsy. Then cone biopsy is better if the reach to the CIN3. Okay, for CIN1 and 2, it can be regress, you know, with time, with treatment and follow-up, it can be regressed to the normal. But in CIN3, we have to do the comb biopsy. So we will prevent the cancer. Okay, as I told you, in Singapore, there is no more cervical cancer because they have this screening test. Okay.
Doctor,
yeah.
In the normal side, the side which is not infected, the upper part is usually made up of squamous cells, right?
Yeah, all squamous. Yeah.
So in the basal layer, what about the basal intermediate?
See, this is the basal layer, the more darkly stained. Okay, this is the parabasal. It is layers: basal, parabasal, intermediate, and superficial. The outer layer is superficial. So why we like the pap smear? Remember the pap smear? It gives the pap stain is gives the different color of the cells. So the basal layer and parabasal layer, they give the blue color, and also intermediate, which is more bigger cells, but it gives also blue color. In the outer cells is pink color. So we know in Pap smear we can differentiate between, you know, the cells.
Doctor, they all squamous cells?
Yes, they are squamous cells, all squamous, but this is maturation, as I told you. This is a kind of maturation. Basal layer is like quiescent cells. Not quiescent, I mean the niche. It gives this, if there is any damage on those cells, so from parabasal, they can mature more to go up. Because mitosis here, division here, more in basal layer. Okay? Okay, understood?
Yes.
Yeah.
So we can go to the second case, the third case. Okay. Second case is what? For the. Okay. Second case, a 45-year-old man presented with rectal bleeding. The doctor advised him to undergo a colonoscopy. He was told that there were many polyps in the colon and should have a prophylactic total colectomy. Look at the gross specimen and describe the abnormality. What do you see?
Formation of multiple polyps.
Yeah, numerous, many, more than, you know, maybe this one is more than 500 polyps. 500 to 1000 maybe. Look at the polyps. Have you seen this one? We call this pedunculated. Okay, is it clear? This one. This one, can you see?
Yeah, whitish gray.
Yeah, it's a grayish polyps, numerous polyp. What do you think the measurement? Maybe 0.2, isn't it? Those are small, very, very small. The measurement, maybe 2 cm, like the 1 cm, those 2 cm. Okay, they are pedunculated. Pedunculated mean they have neck. Okay, and also sessile, meaning sessile like those, doesn't have neck. Okay, and you know these polyps, maybe one of these polyp, if we cut here, maybe we can see cancer or something, isn't it? What do you think this is due to what? Due to what?
Carcinogens.
What type of carcinogen?
Mercury.
Is what?
Low fiber intake.
Yeah, low fiber intake.
This one is what? What do you think? Why this patient has numerous polyps?
Adenoma?
Yeah, it is adenoma, but due to what? What do you think due to what?
Gene?
Yes, gene mutation. What type of gene mutation?
Doctor, is it ABC gene mutation or not?
Yes, very good. APC gene, adenomatous polyposis coli gene mutation. This gene is considered what type of gene? What type of gene?
Tumor suppressor gene.
Yeah, very good. It is tumor suppressor gene. Okay. Okay, we'll go to our case. Okay, what do you see? What do you think is composed of what? All these one? What are these?
Columnar epithelium.
Yeah. So all the structure is glands, isn't it?
Yeah.
So we call polypoid structure. Polypoid structure composed of mainly of gland. Actually, the polyps we said is a protrusion from mucosa. So you can see the whole polyps is lined by what? By glands, isn't it? So polypoid structure usually composed of epithelium and connective tissue core, isn't it? This is a support. Connective tissue core means to support this, the epithelium. Okay, support and support for what? For connective tissue and blood vessels formation. So it is polypoidal structure covered with columnar epithelium and connective tissue core. Okay, look at this mucosa. So what do you think? What's this look like? See, how is it?
Finger-like projection.
Yeah, finger-like projection, but the end is wide, so we call this tubular adenoma. But if you look at this like tapering end, can you see those? And also this one, this we call villus. Usually villus is have very sharp end. Okay, but this who has broad wide tapering end, so we call this tubular adenoma. Okay, so mostly it's composed of what? Tubular or villus?
Villus.
No, I can see tubular. See?
Tubular.
This is tubular. See, this also area tubular. Few area only have villus like this. See, this also tubular. So in this case, some books, if you read how to say tubulus or villus, should be 50-50, okay? But the villus adenoma is more precancerous. So some pathologists like to report is like tubulovillus because even the component of the villus is less, but they like to mention because this more precancerous than tubular. I mean, both are precancerous, but villus can progress easily to cancer more than tubular. Okay. So we have to look at the glands inside. See, the gland is like tubules, isn't it? Rather than round. Look at the normal gland here. Look how they are. They are round, right? And they composed of one layer of the columnar epithelium containing goblet cell. Can you see the goblet cell? And the basal located nuclei. Can you see? One nuclei, isn't it? One layer of nuclei. Okay, compare this gland. This is normal gland, okay? Can you see the abundant goblet cells? A lot of goblet cells. Okay, compare with this gland. What happened to this gland? Those glands.
Less goblet cell.
Elongated.
First, they are more tubular, see, elongated, okay? Second, can you see a lot of goblet cell? Less goblet cell, right? Less goblet cell.
Yeah.
Indicates, you know, how do you know this is mild or moderate or severe dysplasia? When you see the number of goblet cells. Here maybe in this area is moderate because you can still see some goblet cell there. Okay, look at the lining. Is it one layer?
No.
No, multi-layer, isn't it? Look, is multi-layer of dysplastic epithelium. Okay. Also, then we can see the features of malignance is high in C ratio, right? Hyperchromatic, some of them they vesicular. I can see here the nucleoli. Can you see the nucleoli? Those inside the nucleus. Okay. Mitosis also, you can see mitosis there. Understood? See, but the dysplasia is still within the gland. Okay, no invasion. Okay. Some area like here. Few goblet cells, isn't it? Not too much. What else here? See also here. Some areas show moderate dysplasia, right? And some area severe dysplasia. Like this gland, I cannot see a lot of goblet cell. Few only goblet cell, and you see more dysplastic epithelium. Can you see there?
Oh yeah, doctor, what are those cells? The ones we just talked about?
The goblet cell? This goblet cell?
No, you pointed at something else.
Where? This one?
On the right. Yeah, right.
This is the dysplastic, more dysplastic, see? No goblet cell here, isn't it? Few only there. Okay. So, they said this is the stalk or the connective tissue support. Okay. It contains the collagen fiber and blood vessel. Okay, they said if there is invasion to this stalk, okay, if we see some glands inside the stalk, that means there is invasion. In this case, we cannot say adenoma. In this case, we can say adenocarcinoma. Once they invading the stalk, because this stalk is connecting to the the lamina propria of mucosa. You know the lamina propria, remember? Yes. The lamina propria of mucosa. Lamina propria, we said within the glands, isn't it? If there is invasion, that means it is invading. No, sorry. Is I think is connecting to the submucosa, because submucosa they have this kind of blood vessel and connective tissue. If there is invasion to this stalk, that means it is invading to the submucosa. In this case, we call adenocarcinoma rather than adenoma. But if the changes only in the polyps in the epithelium or the polyps here, is still considered adenoma. Understood?
Yeah.
Doctor, what's that big purple circle in the middle of the stalk?
This one.
No, down. In the stock, in the pink area, there's a purple circle.
The connective tissue.
Yeah, this one. No. It's just below it. Yeah, that one.
This one is the lymphatic.
No, doctor. There's a big purple circle.
This one?
To the left. To the left.
All this lymphatic.
Below the lymphatic. Yeah, big circle.
Below. You mean this one?
Yeah.
Yeah.
Okay, we can see what are these.
All lymphocytes.
Yeah. This is lymphoid follicle. Okay. And this is blood vessels. Okay. Okay. So, how to describe? Look at the representative section of the specimen and describe your findings. We said polypoidal structure composed of tubular glands, isn't it? With and fibrovascular connective core or spoke. The tubular glands are lined by dysplastic columnar epithelium, right?
Yes.
So less goblet cells and features of dysplasia, which is high NC ratio, hyperchromatic, polymorphism, mitosis, right? This is, I think, no invasion to
connective
talk. Okay. Some areas shows villus adenoma. See, this is the villus adenoma. Villus adenoma. It's like a villus adenoma. Okay. See, this is which is the sharp end. We call villus adenoma, like villi. Some areas still show mild dysplasia. Some areas show moderate. Some areas severe dysplasia. In this case, what type of dysplasia we can say? Like here is severe dysplasia. Okay. In this case, we can say 2 to 3 dysplasia, isn't it? Mild to moderate to severe dysplasia. Okay. Name this condition.
Edematous polyposis.
Tubular adenoma in familial adenomatous polyposis coli.
Familial adenoma.
Name the genetic abnormality.
APC.
APC gene malfunction.
The mutation of APC gene. Okay, tumor suppressor gene. Is autosomal dominant inheritance. Okay. So, you know, if the patient have this kind of numerous polyps, maybe one of them already changed to the cancer, you know. Once the patient, if he had by colonoscopy, say numerous polyps, in this case, we have to do the total colectomy. Is as a prophylactic, because one of these polyps can progress to adenocarcinoma and invasion, can cause invasion and adenocarcinoma. Okay. Sometimes people, they have one polyp invade or tumor. In this case is, adenocarcinoma in background of adenomatous polyposis coli. In this case, we cannot say just tubular adenoma. In this case, he has already cancer. We can say adenocarcinoma in a background of adenomatous polyposis coli. Okay? Understood?
Yes.
Okay. Okay.
Doctor?
Yes.
You said the condition is tubular adenoma in a background of adenoma 2 polyp.
Not in background, in adenomatous polyposis, familial adenomatous polyposis coli. Yeah. Actually, this is usually have in familial. It is run in family. It is due to the genetic mutation. Okay. Okay, fourth case. Understood this case?
Yes.
Yes.
Yes, doctor.
You know, in exam, maybe I can give you one case of practical, but you know, mixed with theory. Okay, I mean, why we spend time in the practical cases is very important, because in the exam we can give you one case. At any case of the practical, we can also add some theory there. Okay.
Alright.
Fourth case is a 49-year-old man presented with history of persistent cough for 6 months despite a few courses of antibiotic. Lately, he developed hemoptysis. He has been smoking cigarettes since he was a teenager. Repeated chest X-ray showed features suggestive of pneumonia. Look at the microscopic slide from the specimen and describe your findings. We have actually this one a case. Can you see there? If you have like this lesion, you just say it is. What do you expect? You know what? How you can imagine what's this area? Hello?
Black area.
Pardon, doctor?
This area is what in the lung?
The bronchial.
Yeah, this is what you call hilar area or hilum. The hilum, you can see the blood vessels, right, and bronchus. So, can you see this tumor? The tumor is irregular, isn't it? Actually, we don't have this specimen, but I give you the, photo. We don't have specimen, but just to imagine with it, to correlate with the our slides. Okay, look at the tumor here is whitish tumor, isn't it, and irregular. Can you see the irregular? What do you think? This is the bronchus. Can you see that? This is the bronchus. They arise from bronchus actually. Here is blood vessel. Can you see the blood vessel inside the blood vessel? Blood there. So most of the carcinoma is arise in the hilum. Actually, in the why there is black color there?
Necrosis?
Chakul.
What do you think? Smoking. Yeah. Yes.
Smoking the tar from the smoke.
Yes, very good.
Tars.
Okay. So we go to our slides. One. Okay, what do you see? Okay, look at here. This is the alveoli. Can you see that? The alveoli contain air. So what happened here?
small cell carcinoma.
Yeah, there is mass here, isn't it? See the why the patient he got dyspnea. Dyspnea means he cannot breathe, isn't it? Because the tumor is inside the alveoli. No, see? Okay, you are with me. This is a tumor within the alveoli, isn't it? Occupying most of the alveoli. Okay. So what do you think? Lesion where? Started where? Can you see this area? This area is what? Is a bronchus. You know? Look at here, the bronchus. This is the collagen fiber. Not collagen, sorry. What you call cartilage. When you see cartilage in the bronchus, okay, cartilage. Okay, so this is a bronchus. Can you see? This is a bronchus. So what happened in the epithelium? Is it normal epithelium? Okay, I will show you the normal one. Here, like what we have. Okay, look at here. This is this one, another bronchus. Look, this is a bronchus. How do you know the bronchus? The presence of the cartilage. Okay. And also the muscle there. So this is the lining. Look at the lining. How is the lining? It's lined by columnar epithelium. Ciliated. Okay. Okay. Compare this. This bronchus. Okay, with this one. Is there any lining? Columnar?
No.
No.
Became squamous.
Yes, very good.
Metaplasia.
Metaplasia plus, is it normal squamous?
No.
What happened?
Dysplastic squamous.
Yeah, dysplastic. See, actually, first there is metaplastic. It becomes squamous. Second, this metaplastic epithelium is because of the continuation of the smoking. See, the patient is heavy smoker, isn't it?
Yes.
And long time he smoking. Maybe he 20 years he smoking. Okay, so the stimulus is not removed. So the persistence of smoking causes metaplasia. Then this metaplastic epithelium is progressed to dysplastic, even mild dysplasia to what? Is it mild or moderate or severe? What do you see? Can you identify? Severe, because it is involving the whole thickness, isn't it? Okay, we know the sign of dysplasia: loss of maturation, orientation, high NC ratio, right? Here, there is no hyperchromatic. Mostly it's vesicular nuclei. Look, the nuclei is vesicular. Okay, increased mitosis. Then this one, with the patient still continue, smoking. So this carcinoma in situ or the severe dysplasia progress to what? It invade the wall and reach to the alveolus. Understood? So this is the tumor within the alveoli, already invading the wall of the bronchus and invading to the alveoli. So this is what you call infiltrating carcinoma. So how do you, what type of cancer here?
Malignant.
Yeah, malignant what? Squamous or adeno or
Squamous.
Squamous cell carcinoma. How we know the squamous?
Because the lining of the alveoli is made of squamous cells.
Is it the alveoli lined by squamous?
Bronchus.
We said the tumor in the bronchus, actually, isn't it?
Yes.
Okay, in this case, it's difficult to find. Usually we said squamous cell carcinoma. In squamous cell carcinoma, how we know the
Keratin pearl.
by presence of keratin pearl, isn't it? Can you see here abundant keratin pearl?
No.
No. So in this case, what we can call this? Maybe here, see a bit keratin there. Few
Oat cell carcinoma?
No, oat cell, they are usually small like this, like lymphocyte. But this is very big cells. Okay, but got some keratin pearl, a bit, few. We call occasional keratin. Can you see that? Occasional keratin pearl. Okay, this one. You know, in this case, if I have like this case, I have to do mucin stain. I need to do other stain just to, you know. But I already have this, you know, carcinoma inside too. This one prove that is the tumor is arise from bronchus and is due to the metaplasia of the epithelium. And also look at the cells. Look at the nuclei. Is the same as those in the alveoli, right? Look, we compare between both. Same, isn't it? That means they are actually arise from that bronchus, which is this plastic bronchus. Can you see numerous mitosis? This is mitosis. See? The irregularity. This is mitosis. When you see a lot of mitosis, indicate what?
Dysplasia.
Is it dysplasia? This is already infiltrating tumor. But if you see a lot numerous of mitosis, indicate what? This tumor is what? Highly proliferative.
Grade 3?
This one is already poorly differentiated because we cannot see the a lot of keratin pearl, but we identify it is squamous because we still see occasional keratin, you know. Here, can you see there? Occasional means seldom to find the keratin. Why we said poorly differentiated? Because we cannot see abundant keratin, a few keratin only. Okay. Here, what are these in the center? What's this?
Blood vessel.
Do you think this is blood vessel in the center of the tumor? Can you see? What are these?
Necrosis?
Yeah, necrosis. Okay, if you see the tumor has necrosis and abundant, you know, mitosis, that means this tumor very aggressive and highly proliferative. Okay, so we say the tumor is arising from this plastic bronchi and invading the alveoli in the form of nest. You know, this nest or mass. This is round mass or nest of large malignant cells showing high NC ratio, large nuclei, vesicular nuclei, many high NC ratio polymorphism, also have abundant or many mitosis there, and we can see occasional keratin pearl, isn't it? Occasional here, occasional keratin, and also the tumor show necrosis, there central necrosis. See, also this central necrosis, can you see? Yeah. The necrotic area usually invaded by inflammatory cells, also here, necrosis. Can you see that? See, this is a necrosis also. Okay, look at the cells. Can you see any intercellular bridge?
No.
No. Yeah, as I told you, in squamous cell carcinoma, the poorly differentiated, you cannot see the intercellular bridge. But in well differentiated, we can see the intercellular bridge, and also the cells is quite large, polyhedral, and they can see the cytoplasm is eosinophilic. Here is actually poorly differentiated squamous cell carcinoma.
Doctor, having a vascular nucleus is also a sign of malignancy.
How what?
Having a vascular nucleus.
Oh, vesicular nuclei. This is vesicular nuclei. This is when it is not hyperchromatic like those, like this, we call vesicular nuclei. Understood.
Doctor, can you repeat about the vesicular nuclei?
Okay. Okay. Vesicular nuclei usually this one, which is has, have deeply stained membrane. Can you see the membrane? Okay. And pale center. This is vesicular nuclei. Most of them like that. See, look at here. The basement membrane is deeply stained, but the central is pale. Most of the squamous cell carcinoma, they have this, the vesicular nuclei. These are mitosis, mitosis there.
Thank you, doctor.
Okay. Any question?
Doctor, the name of this condition is bronchial carcinoma?
Bronchogenic carcinoma. Especially poorly differentiated squamous cell carcinoma. And there is focus of what? We just say poorly differentiated squamous cell carcinoma, or what? What else? What else? We discover. What else?
Metaplastic.
And focus of carcinoma in situ. Isn't it? Okay, name this condition, poorly differentiated squamous cell carcinoma of the lung, and focus of carcinoma in situ. Okay, explain the cell origin of this tumor. Cell origin from where?
Dysplastic bronchus.
Yeah, bronchial lining, which is undergoing squamous metaplasia due to the irritation of the chronic smoking, isn't it? What is the prognosis?
Bad
Yeah,
prognosis.
poor prognosis. It's nice if we say poor rather than bad. Poor prognosis. Yeah, why? Because it is already invading the alveoli, isn't it? So So in this case, the patient will have radio and chemotherapy.
Doctor, this patient won't undergo surgeries to like remove the cancer first?
Yeah, they will. Actually, it's according to the stage. You know, if they're still stage 1 or 2, they can remove. But stage 4, difficult to. I mean, stage 4 already metastasized, so they can give just chemo and adjuvant chemotherapy and radiotherapy.
Doctor, is it possible to do a transplant, a lung transplant, if it reaches very badly?
Actually, why transplant? You just remove a small area, not the whole lung. I mean,
What if a lot of the lung has been inflated?
This is not the whole lung, you know. This slide is the tumor area. But we have to do the white excision, you know, white excision to see the margin. Okay. Yeah. Any question? Okay, if the tumor in the apex, if we see mass in the apex of the lung, what do you think? In the apex, if there is mass, in this case, we think not only the tumor, because TB also can give an X-ray as mass in the apex. In this case, we have to know we have the only by biopsy. Because in the apex we can most of the adenocarcinoma, not squamous mostly we said in the hilum, here in the hilum, but in adeno usually at the apex of the lung, most of the adenocarcinoma. Okay. Any question? I think we have finished, isn't it? No more case. Understood the practical?
Yeah.
Doctor, so if it infected the apex, then it become an adenoma, is it?
Adenocarcinoma.
Adenocarcinoma, alright.
Most of adenocarcinoma, because in the lung cancer is the bronchogenic cancer, I mean, it is types, is squamous and adenocarcinoma. Adenocarcinoma usually arise from the columnar epithelium, okay? Squamous is from bronchus, but because of metaplasia, so why it is squamous. Also, we can find that Ott cell. Ott cell is bigger than the lymphocyte, maybe 2 times only, and large cell. It's all considered a bronchogenic. Bronchogenic means it arises from bronchial epithelium. So adenocarcinoma usually have the apex, but in the hilum usually the squamous cell carcinoma and the small cell carcinoma or Ott cell carcinoma. Okay. Okay. We in specimen we don't have this specimen. So in a specimen we have this only. Even in the exam I will not give like this. If gross, because we don't have the gross. We have only this in practical. Okay. Also we don't have this. So in today practical we have only this course. Okay. This one just additional because I need you to understand how the all-in-one populace is. Also this additional. and this one also additional. But our specimen, we have this specimen. For dysplasia, we have only this specimen. Okay? Okay.
For that one, you mentioned pedunculated. What does pedunculated or sessile mean?
Pedunculated, we said they have neck. Okay. See? They have neck. عنق معناها عنق. Sessile means doesn't have neck, so they stuck with the mucosa. Those are small, those. Okay, this one doesn't have the neck or stalk. Pedunculated. This one pedunculated. This pedunculated. Okay.
Allah shukran.
Understood. Any question? Any question? Any question?
I think no, doctor.
No. Can you wait a bit? Don't go out.
Yes, doctor, we can.
See, tomorrow you will start with Prof. Nani, right?
Yes, doctor.
So you have Wednesday and Thursday. Friday I will give you the practical, okay?
Right, doctor.
So I can see you on Friday.
So doctor, after that we're basically done with all our lectures and practicals.
Yeah, by Friday, that's mean we finish everything.
Yeah.
So we can have a good time for revision.
Like, which, yeah, for you to revise 2 weeks. Yeah, wow. It's not happen in any block.
2 weeks, doctor. Until when? Oh.
Because the exam on
Till
10th of April. Yeah. So revise, and if there is any question, you can ask me. You just text me. Okay?
Okay, doctor. Okay, doctor. Have a nice day.
Okay, on Monday, the next Monday is the quiz. So it will include all.
Oh,
Doctor, does it include the practical or just the lectures?
No, theory only.
Okay.
All right.
Okay. Haji, can